I would like to invite Dr. Sridhar, PS. He is Director of Cyberknife and Senior Radiation Oncologist from SCG Hospital, Bangalore. So over to you, Dr. Sridhar.
Thank you, Preeti and Banu and Venu Sridhar and all. And we had an excellent lecture by Dr. Satish and Iqbal. That is what the robot is doing for today, as for today. So I take this opportunity and tell about one of the interests what Dr. Iqbal presented is the artificial intelligence as the future. So I would like to change that to artificial to accumulated intelligence. So it's actually what we see in artificial intelligence. What we see right now is a one doctor who is brilliant, or any of the things is a multiple brains are accumulated and the intelligence is accumulated. So I won't call it as an artificial; it is an accumulated intelligence. So that is a nomenclature to be changed, because artificial is always artificial, but it is definitely AI is the future. So can I have my slides? Actually, like it's just to give that background. The robots are first used. I'm proud that robots are first used in radiation oncology, and we adopted almost around 15 to 20 years back, almost 20 years back. Can I have my slides?
Sure, sir. I'm sharing your slides. You can just guide me through.
Yeah. So I would like to talk it as like SBRT Cyberknife as a new dimension. So that is the whole of landscape of oncology is changed, especially with the help of the Cyberknife. I'm going to take around 20-25 minutes. Next slide. So these are my credentials, and this is the flow of the chart, what I'm going to talk about. No problem. Next slide. Yeah, so we are doing for almost around 13 years now. These are the newer things, what they probably, it may be new to you people. The SBRT means stereotactic body radiotherapy. What is the standard of treatment? And immunotherapy is another thing what is coming up in a big way. Next one. So the pillar of cancer care, if you see, the surgery is the gold standard, which is almost like a 1 century ago, and it's a radiotherapy, medical oncology, molecular targeted therapies, and the immunotherapy. So immunotherapy is one of the things which is coming up in a big way in oncology. These are the 5 pillars of oncology, what we can call it as. Next one. So when we are talking about this, we are very clear that the radiation part of it is one of the main pillars of oncology. And in oncology treatment, it is not like in the past. We are looking for very, very clearly quality of life, effective treatment, and like definitely the extensibility of life. So that is what we are looking at. If you take an average, the days, every 75 days, there is a change in the treatment plan of oncology. So everything is evolving so fast. It may be with the help of the molecular oncology and the newer molecules which is coming, and the technique of surgery, technique of radiation. The bottom line is local control, extensibility of life, good quality of life. So these are the main things what we are looking at. Radiation is technically given as a use of external radiation, that is high energy X-rays to a very, very precise areas, where we are giving conventionally 5 days a week to 5 to 7 weeks of radiation, mainly keeping it in the radiobiology of tumor, where there is an effective treatment to take care of the cancer, and the normal cells, which is given the radiation as an inevitable process, it has to recover. So the conventional, then with the help of the newer techniques, we are able to change the type of radiation, where high dose is given, the short duration, and to a precise dose, that is called hyperfractionation. The number of days of 7 weeks is reduced to only for 5 days. So that is in the brief about the overall radiation fractionation schedule. So by giving these hyperfractionations, we are able to deliver the radiation dose very effectively to the tumor. There is a very steep dose fall. Because of that, normal structures gets very, very less dose. Then because of that, effectivity of the treatment is better. The tolerance is better. Like as we seen that with the help of the robotics, the patients, one of the main advantage, apart from the local control, the quality of life of the next day the patient goes off. Like it may be a major surgery where we are talking about, like it takes a long time of 2 to 3 weeks of recovery period. Same thing with in terms of Cyberknife, the treatment related side effect to the surrounding structures are so less, the effectivity of is definitely better. Because it is taken care locally, local control is better. Definitely, it is extensibility is one thing what we are looking at across all the tumors. And it also acts as an abscopal effect or immunomodulation. When we give an high dose of radiation to the tumor, there is something called cancer stem cells. Those are also get affected and the cells dies. Those cells which are dead are produces the antigen effect, and the antigen effect, which the antibodies produced in the body, acts as a cancer vaccine and acts all over the body, and the effectivity of the treatment increases. When I started 15 years, when we are giving multiple areas, some of the patients were like pancreas and liver cancers. When they survived for more than 3 years, we thought that they are not fit to alive. They are not supposed to live according to the literature. So now we are realizing the radiobiology of the effectivity of the Cyberknife and the high dose radiation that acts as a systemic effect. So radiation is no more a local treatment like surgery. It also a systemic treatment like chemotherapy and immunotherapy. Next slide. So whatever the things, what we newer things come, the basic thing of the human touch and seeing the patients has to be there. So I always give that importance. The history and clinical examination is important. What is best we need to incorporate is biopsy and genomics in each patient. One time, one stop investigation is the PET CT scan, which we do it mandatory, and multidisciplinary team is important in taking a decision for cancer management. And the MRI brain screening for lung cancers and TNBCs. So I always say that there is no sorry word in oncology. So with the doctors, we have to be very clear to avoid the sorry word and treat the patient as effective as possible. Next slide. So Cyberknife is nothing but a robotic assisted radiation one. We have next slide. So linear accelerator is mounted on a robotic arm. Just switch on that. So there is a linear accelerator mounted on a robotic arm, and there is a table which moves in 6 directions so that the effectivity of the treatment is better. There is a continuous tracking of the area of tumor by the help of the X-rays. So all the patients undergo the PET CT scan. There is something called digital reconstruction radiographs. A library of the images are formed in almost all 6 directions, and whatever the direction change, we'll have that reference image which is already kept. So we need to, when the patient comes, which lies on the couch, the images are taken again, and whatever the easiest image which is nearby, it is exactly matches to that and correct itself. And with the help of the robotic arm, we can correct the motion, and it continuously track exactly the way where we want it to treat to the particular tumor. So this goes on and continuous process. That is so we call it as a step and shoot. We use the 60 skull tracking, spine tracking. Wherever there's a soft tissue, we use fiducial tracking and the lung tracking. So these are some of the things we use for tracking the tumor effectively. So because of his eye tracking method, I don't give any margins. I use the PET scan and the MRI for the tumor delineation and treat only that and treat effectively. The most of the side effects in the oncology is because of exposure to the normal structures, especially in radiation. That is least in case of cybercare. We track the respiratory movements, we track the tumor in continuous, we synchronize these movements, and the robot can treat all along the respiratory phase only to the tumor. So that is the beauty. Because of that, even the elderly people, patients who have a less general conditions can also be treated in this condition. Even to the extent of palliative treatment, it should be in an effective way, so can be treated very well with the help of the Cyberknife. Other than the radical treatment, what I'm going to tell about that. Next one. Just click once more. Yeah. So here, like as you can see, it's going to track the tumor continuously all along the phases of respiration and treat very, very effectively. This is the advantage with Cyberknife rather than any other linear accelerators where there is no margins are involved. We treat only the tumor with the help of the fiducials and the synchrony. So there's in a normal other linear accelerator based, we give a margins. In case of Cyberknife, I don't give any margins. I've treated more than almost around the total number of cases. We have crossed almost around 4,800. My contribution is around 3,500 cases. Lung, especially, is definitely it is going to be some of the more than 400 lung cases I've treated. Only see a carcinoma lung primary. Metastasis is a separate one. Next one, please. So the Cyberknife, the main thing what we are looking at is high precision tracking, very effective motion management, high dose delivery, rapid dose fall to the normal structures, and patient friendly. Patient can take the off when they're treating. If they get bored, usually it takes around 45 minutes for each day for 5 days. And in between, if they want to take a break, they can come, they listen to the music, it will start from there. And knowingly also, you cannot override and treat. Next slide. So the applications is it has a brainchild at the neurosurgeons. Basically, it started like all the intracranial lesions, the benign and malignant, and even functional scale one like trigeminal neuralgia. I call it as all acoustic schwannomas, meningiomas, AV malformation, brain metastasis, and some of the melanomas, and also the paragangliomas can be treated very well with Cyberknife. I would like to tell wherever there's a neurosurgically, the surgically inoperable or residual lesions or recurrent lesions can be treated very effectively with Cyberknife. And lung tumors, primary lung, including the metastasis, or include what we call it as an oligometastasis now. The classic indication of lung is the small lesion, early stage, patient is not eligible for surgery, medically inoperable, or patient does not want surgery, can be considered for Cyberknife. And all cases of spinal tumors where there is a residual or metastasis can be considered. And hepatobiliary, the pancreas, as like the Iqbal was talking about, like considering for the surgery. If it is surgery is possible, that is the best treatment. If it is not possible, medically inoperable, or patient does not want surgery, the biggest advantage of Cyberknife is a non-invasive and equally effective as good as a surgery. And same to the HCC, the size of the lesion should not be an issue. We see a lot of patients of HCC from it, especially from Middle East and Africa. I travel extensively to these countries, and we see a lot of patients, and we treat effectively these cases. Cholangiocarcinomas, gallbladder, and which is inoperable or metastatic. And some of the kidney tumors, RCCs, where there's a partial nephrectomy or patient does not want, even in the patient, there is a category called oligometastasis, where there's a primary with a single or like a 2 or 3 metastases can be treated very effectively with Cyberknife. Prostate cancer is another biggest advantage, where the patient does not want to undergo surgery, or the surgically, like when you see equally effective results can be given with low to intermediate, even to the high risk, even to the metastatic disease. Treating the primary of the prostate is most effective. So next slide. So these are the indications. Even the soft tissue sarcomas can be treatable. Next. I've already gone through this. Carotid body tumors is another one. The trigeminal neuralgia is another one. So metastatic in anywhere in the metastasis. Next one. So we have a permutation and combination of adding the external radiation, or decrease the tumor and go back and consider for surgery, or use the chemotherapy or biological agents or immunotherapy along with that. Next slide. Next slide. So as I told you already, we have done around 4,500 odd cases, and these are some of our reports. Next. So when I talk about 4,500, sometimes oligometastasis, one patient I treat more than 4 or 5 areas. If I take those into considerations, we have treated more than 7,000, 8,000 sites. Next slide. See, the lung cancer, I would like to concentrate on the lung cancers, hepatobiliary and prostate. This is some of our data. And we're like the whole staging system, I tell you that the one lung metastasis or any metastasis in the past is considered to be an incurable disease. It is not no more like that right now, especially with the breast cancer. We can treat with oligometastatic to into a definitive intent. Some of my brain metastasis patients are surviving 8 to 10 years, and that is what is the one what we are looking at. This is one of the patients with the lung cancer with bilateral carotid block. Next slide. We use the PET scan and MRI as and when required. Very specifically, if you see, it is definitely the side effects of the normal lung exposure is less. Because of that, tolerability is better. Next, because of that, quality of life is better. This guy I treated in 2010, and then with a single modality, not even any of the EGFR, the biologicals, and he was up to 4 years. He was fine. He has progressed over one brain metastasis. We treated that, and I've treated 4 times with this particular patient, and he succumbed to the disease. Is almost around surviving for 8 years. Next one. Another patient with adenocarcinoma from Africa with a lymph node. She didn't want it to stay for 6 weeks of radiation-based concurrent chemoradiotherapy, the standard. We treated the primary and the lymph node. Yes, multiple areas can be treated. And then we put her on the chemotherapy for a short period, and then she's absolutely doing fine for almost around 6 years. Next slide. Yeah, 2016 started. She's doing still fine. And one of the thing is post-treatment changes of lung pneumonia or pneumonitis is the least. They're all recovers very fast. You can see this scar formation, which is only limited to the tumor. So the quality of life is good. Next slide. Large volumes, this is a metastatic, this is a squamous cell carcinoma treated with chemotherapy, but the tumor progressed. Large volume tumor, along with the immunotherapy combinations we use. For our surprise, when I did it for the second, after 2 weeks itself, you can see the big response when I simulated for the liver. Next one. He had a liver metastasis also, that is also treated with Cyberknife. And after 3 years, a lot of times these people stop chemotherapy. That is where the tumor starts progressing. So like he succumbed to the disease after 3 years. But the primary area, wherever we treated, it has shown very good results. Next one. Here another patient presented with the CA lung with a brain metastasis, next slide, and adrenal mets in the primary. All 3 are treated with the Cyberknife and continued with the chemotherapy. Next. 2017 treated. So we just spoke to him last week. He's doing absolutely fine. So 5 years with the CA lung, with the stage 4, with the brain metastasis, doing absolutely fine with a good local control. So one of the dictum is the changing scenario of cancer management is changing cancer into a chronic disease is one of the things we need to understand. And we should not just dump it like a metastasis, nothing can be done. Effective way of treatment makes it the patients to survive more. Next one. We have some of our publications. See, I always believe, as Dr. Iqbal was telling, that we need to keep up with the pace. Whatever the management, what we do it, we need to do it for the future also. There's some of our data of immunotherapy, SBRT and SBRT alone, which is published, which has shown a very good results. Pancreas is hepatobiliary and pancreas. Pancreatic tumors, only 5 to 8% of the patients goes a clear-cut surgery, which is a curative intent. Because 30 to 40% of the patients will always have a borderline and they go for chemotherapy. Chemotherapy is not effective. We are not able to give effective chemotherapy, reduce and then doing surgery. So instead of that, we can use for 70 to 80% of pancreatic cancers with control the local disease, go back and do the surgery is the one what we are looking at. Next one. So the surrounding treatment-related side effects are very less in this. I've done around 100 odd patients, and the median survival, we are talking about 3 years. We are publishing this data. Next one. We add hyperthermia as and when required. So this is an 80-year female where we treated with the CA pancreas, treated with Cyberknife. Next. Duodenal infiltration, the people say the contraindications, I can still treat. There's one of the patients where we can see that there is a duodenal infiltration was there. Effectively, the PET scan shows almost complete metabolic response and the tumor is reduced. Next. HCC is more than the dictum of HCC is liver transplant. If it does not happen, a lot of times it's coming to the end of the road. So, but like SBRT plays a role, the Cyberknife with up to 40 to 50% of the patients we can treat even in a metastatic setup. Portal vein thrombosis and the size of the lesion is not a problem. Bilirubin is a contraindication for starting any of the medical management, but Cyberknife can still be considered even with the background of cirrhotic liver. So that is one of the things what I like to insist. Next one. This and the age. All these patients are elderly. The effective treatment. This is a 74-year guy, 2011 treated. Next slide. I've done 3 times Cyberknife to this guy with the progress in different times. He survived up to 2000, like almost around 8 to 9 years. Next one. We didn't start at sorafenib up to 3rd recurrence. Next time, please. So there's another classic indication of Cyberknife with the big lesion. So this guy is from Maldives. Next one. He survived for almost, is still alive, treated in 2016, is almost 6 years. So there's a retroperitoneal sarcomas, Ewing sarcomas, also soft tissue sarcoma also can be treated with the big lesions where it becomes inoperable, medically management becomes a challenging. Next one. Prostate cancer is very, very important. We are going to see more of prostate cancer in coming years. And there is an effective, I am looking for a definitive or a curative intent for prostate cancer, where with the help of PSMA PET scan, we can treat with the Cyberknife effectively. Next is only short course. Sometimes we don't even give hormones for up to intermediate risk. Next one. The treatment-related side effects is very, very less, and they live longer. We need to make sure that it does not come with the side effects. Next slide. Yeah, recurrent tumors of the prostate cancer also can be treated, and the metastatic prostate cancer also can be treated. Even the metastatic sites we treat. Next slide. The bladder tumor. There is a certain type of patients where the patient refuses to go for bladder reconstructions, and these are the patients where we can consider for Cyberknife boost, where organ preservation is one of the dictum. I'll just take 2 minutes, Preeti. Next slide. Yeah, this is one of the Cyberknife patient boost, where we have done around 15 patients where organ preservation, where around 85% of the local control over a period of almost 11 years. Next one. Yeah, to conclude, the SBRT is effective, and that is the Cyberknife is most effective and most friendly. We can treat for the primary area, we can treat for the recurrent, large areas, metastatic, and SBRT with immunotherapy is the one what we are exploring nowadays, which has definitely have a more effectivity. Thank you for your patient hearing. Next slide.
Thank you very much, Dr. Sridhar PS, for your wonderful presentation. I have 2 or 3 quick questions. You have been talking about Cyberknife for solid organ malignancies, optical malignancy.
Yeah, even sarcomas we still consider as
hematological malignancy.
Yeah.
No, what I mean to say, when you talk about the immunotherapy, the immunotherapies are mainly the monoclonal antibodies, organ specific and antigen specific. So when we talk about organ specific and antigenic specific monoclonal antibodies in the immunotherapy, can your Cyberknife inject it into the bone marrow for the localization of the leukemia?
No, as for now, actually, if it's a cumulative cells are present as a clonal in one, maybe possible. As for now, no. So, but like when you're talking about the T cells, the immunomodulated cells, that is the oncology in coming years is going to be an exciting era. That's what I can say.
That is what is being studied now.
Yes. I can say that is what is we are looking at. Yeah, right now, hematological malignancy is I'm at the back seat. The front seat is mainly the medical management.
Because immune modulation and immunological therapy are the backbone of leukemia therapy now. And as per the new reports from the United States, almost all type of hematological malignancy, the most dangerous out of all is ALL. And the ALL has been found out to be highly effective to the immunotherapy by injecting those monoclonal antibodies into the bone marrow. So the path has to be devised. How do you enter the bone and how do you enter the bone marrow?
I agree with that. Yes.
Thank you very much.
Thank you, sir. Thank you so much, sir, for this wonderful insights on cancer care. And of course, role of Cyberknife in cancer care is remarkable. That's what we understood. Yeah.
Thank you, Putin.
Oh,
Thanks for everyone for the patience hearing.